My name is Carsten Bo Larsen, and I'm Research Director here at CEPOS, Center for Political Studies in Copenhagen, and I'm the moderator of this debate. We have three outstanding experts in health policy to debate today, and I'm going to make a short presentation of each one of them before we start. First of all, we have Michael Cannon, Director of Health Policy Studies at Cato Institute. Cannon is an influential healthcare wonk, according to the Washington Post, and the most famous libertarian healthcare scholar, according to the Washington Examiner. Washingtonian magazine named Cannon one of Washington's DC's most influential people the last 4 years. And who knows, maybe after today's debate, he will also become one of the most influential people in the Danish healthcare policy debate. Then we have Hans Martens, former CEO of the European Policy Center, a European think tank. There he has worked for many years with European health policy. Today, Hans is president of the General Assembly of the European Association of Value-Based Healthcare. Hans is a very popular keynote speaker on health across Europe, and he has an impressive overview of the healthcare systems in the European countries. Furthermore, Hans is a good friend of both CEPOS and me. Finally, we have Kjeld Møller Petersen, professor of health economics at the University of Southern Denmark. When I was a very young civil servant in the Ministry of Finance more than 20 years ago, I was so incredibly lucky to participate in the work of the Kjeld Møller Petersen Committee, which, as the name says, was led by Kjeld. The committee's analysis led to one of the largest and most successful reforms of the Danish healthcare system. Already 20 years ago, Kjeld had been the leading Danish health economist for many years, and he still is the leading Danish health economist today. I know that Kjeld is too modest to say it himself, so it's good that I'm doing the presentation. Now let's get started. Let's get ready to rumble. We start with each of the three health experts being given 15 minutes to explain the most important problems and successes in the respective countries' healthcare models. Due to the tradition in all CEPOS debate, we use an hourglass to stress the speaker. And we'll start with Michael. The scene is yours.
Wow, okay, better get started. Thank you very much, Carsten, and everyone at CEPOS for inviting me to be here, and thank you all for coming, and most of all, thank you for letting me do this in English. I really appreciate that part. I will be walking through some features of the U.S. health sector that I think come as a surprise to, let me see, have we got it up and going? Yes. To many Europeans and even some residents of the United States. There is a persistent myth in health policy debates that the United States has a free market in healthcare, and all of the troubles we experience in the United States stem from the fact that healthcare is a special sector of the economy where markets do not work, and because the United States relies on free markets to distribute healthcare, it reaps what free markets produce in that sector of the economy. But let me walk through a couple of features of the U.S. health sector that you may or may not be aware of. Okay, so I like to say that in the United States, we not only have universal health care or socialized medicine, we have every form of universal health care, socialized medicine, whatever you want to call it, that any other country has ever devised, and at least one that no other country has devised. For example, most of the U.S. population has compulsory health insurance through an employer, not unlike what you will find in the German system. There are differences, yes. That is a very important similarity between the two, and that is more than half of the U.S. population. We have about a sixth of the U.S. population that has coverage through a program we call Medicaid, but that has a lot in common with the Canadian Medicare program and even the Danish health system, where the national government collects a bunch of money and distributes it to states or provinces in the case of Canada or regions in the case of Denmark, for them to administer a universal health program for an entire population. With regard to, in the United States, the Medicaid program covers a population of only a fraction of the population. It's low-income U.S. residents. But it is a universal program in the sense that enrollees don't pay anything for the medical care they receive, and so it has many features in common with both the Canadian and the Danish systems. We also have in the United States our own version of the British National Health Service, a fully integrated healthcare delivery system where all of the doctors and nurses work for the same entity that owns all the hospitals and other facilities, and that entity also serves in the role as insurer and payer for healthcare. We call it the Veterans Health Administration. It covers about 1% of the U.S. population, those who are veterans of the U.S. military. Not all veterans enroll in this program. Those who can avoid it can. We could talk about that if anyone's interested. We have in what we call the individual market for health insurance in the United States, where consumers buy insurance directly from insurance companies. We have a system much like the Swiss and Dutch system, where you have private health insurance companies, at least ostensibly private health insurance companies, competing to cover consumers who can choose among plans in a very heavily regulated and very heavily subsidized market. Where we innovate in terms of socialized medicine is with the U.S. Medicare program. The U.S. Medicare program covers elderly and disabled U.S. residents, about 66 million of them, so it's about 11 times the population of Denmark. And it is unique among health systems in the United States because, around the world, because the national government purchases medical care and sets the prices for all the transactions governing medical care for this massive population of people across an entire continent. I don't think you will find a more centralized example of universal health care in terms of the amount of power that a national government controls over so broad a population of enrollees. And I think last time I checked, in terms of dollars spent, the U.S. Medicare program is the single largest purchaser of medical care in the world. We also go ahead and throw some people into our version of the Canadian Medicare program and our version of the Medicare program. They're eligible for both. We call those dual eligibles. And then there's the feature of the U.S. health sector that you probably hear most about, which is the fact that we have 8% of U.S. residents who have no health insurance. Now, this tends to corroborate the or confirm in some people's minds the myth that the U.S. has a free market in healthcare, because after all, in a free market, not everybody is going to have health insurance. And so some people don't have health insurance in the United States, ergo, the United States has a free market in healthcare. I think something else is going on with the uninsured in the United States, and it has to do with what government is doing with all of these other programs where it intervenes in order to subsidize and regulate healthcare. In all of these other programs, with the possible exception of the Veterans Health Administration, what the government does with the powers that it has over healthcare finance is it encourages more and more health spending. First, let's talk for a second about just how much control those programs give government over healthcare spending in the United States relative to other countries, and then I'll talk about what they do with that power. So the OECD collects lots of data on member nations' health systems. The one data series that I don't think gets nearly enough attention is when they measure how much health spending within a nation is voluntary versus compulsory. In other words, voluntary, the consumer gets to choose how to spend that money without the government pushing it one way or another. Compulsory is when the government creates some sort of penalty on the consumer if the consumer doesn't do with that money what the government wants. So this could be taxes, so all government spending would count as compulsory health expenditure, but private spending that is where you'll be subject to a penalty if you don't spend money the way the government wants would also be compulsory. If the United States had a free market in healthcare, you might think that in the United States, the share of health spending that is compulsory would be near the lowest among OECD nations. Instead, it is near the top. According to the OECD, 85% of U.S. health spending is compulsory. That puts the United States within 2 percentage points of the top nation on this ranking, Germany, And it means the United States is in a statistical dead heat with France, Czechia, Denmark, and Norway. In all of these countries, government controls 85% of the spending. It would be odd for us to conclude that a country where the government controls that much of the health spending, where that much of the health spending serves the government's preferences rather than consumers' preferences, is a free market. And I should add that is a larger share of health spending than the government controls in Britain, Slovakia, Austria, Poland, or Canada. Britain and Canada, of course, have entirely government-run single-payer systems. So, with all of that power, what happens? What does government do with all that power? Well, this slide is a further indication, indirect evidence, that the United States does not have a free market in healthcare, and it also suggests what the government ends up doing with that power. The U.S. Congress requires lobbyists, those who lobby Congress, to register with the federal government and report their lobbying expenditures. And it turns out that for the past 20 years, the health sector of the U.S. economy has spent more money lobbying Congress than any other sector of the economy, often by far. And if you think about the U.S. military, have any of you heard of the U.S. military, perhaps? Are you familiar with their work? Okay. This is a massive undertaking. The U.S. Congress spends tons of money on the military, and yet lobbying expenditures by the health sector outweigh or outstrip lobbying expenditures by the defense industry by a ratio of almost 6 to 1. Lobbying expenditures by the pharmaceutical industry itself outstrips lobbying expenditures by the defense industry by almost 3 to 1. So if we had a free market in healthcare where the government weren't making any of the decisions, probably there wouldn't be quite so much lobbying expenditure by the healthcare industry. But they do lobby. They lobby an awful lot because the government has an awful lot of power over healthcare in the United States. And what do they lobby for? Well, of course, they lobby for more and more health spending. And principally they do this by lobbying to make sure that all of these types of health insurance are as comprehensive as possible, making consumers as price insensitive as possible, and therefore more willing to demand to tolerate higher prices and to demand more medical care than they would if they were price sensitive. This graph shows one measure of the comprehensiveness of health insurance in the United States. You can see that even before Congress enacted Medicare and Medicaid in 1965, the share of out-of-pocket spending, health spending as a share of total spending, was falling pretty rapidly. It was already below 50% and falling. That was because of the tax preference for employer-sponsored health insurance, which is the reason why most U.S. residents have health insurance through an employer, and which encourages people to consume more health insurance and more medical care than they would otherwise. So that share had already been dropping. It kept dropping rather precipitously after Congress created these two enormous subsidy programs. And it almost sort of plateaued, but not quite. In the 1990s, Congress kept expanding some of these programs. The Medicaid program, they created the Medicaid program, or they created the Children's Health Insurance Program in 1996, and the Affordable Care Act, or Obamacare, in 2020, which took effect in 2014. So that number keeps on falling. It's now about 11%. 11% of health spending in the United States comes from the consumer and goes directly to the provider, which is a pretty small share relative to other nations. And what does this do to prices? Well, if the consumer doesn't care much about the price, then they are not going to shop around on the basis of price. Why would they if 90% of the savings is going to go to the government or to an employer or to an insurance company? And they are going to be much less willing to switch hospitals or switch drugs if their insurance company tries to negotiate lower prices for these items by excluding a drug from the formulary or excluding a hospital from their network. And the healthcare industry gets the message. What the other two lines in this graph show is what has happened to real prices for medical services and medical goods since 1961. They have grown dramatically faster than inflation. If they only grew as rapidly as other prices in the economy, those two lines would be flat against the x-axis. Instead, they've risen dramatically. That was correlation, of course, not causation. There are a lot of other things happening at the same time that could have been driving prices up. More direct evidence is what happened when Congress required everybody with private insurance in the United States to purchase 100% coverage for contraceptives. As you can see here, the orange line shows real prices for hormones and oral contraceptives before that regulation took effect. They were basically falling in real terms, which is good. This is how you make healthcare more universal, through falling prices. But as soon as the government made every consumer price insensitive for these items, the producers of these items got the message, and they increased prices. Prices doubled over about a 9-year period. And so it shouldn't surprise us when we see comparisons of prices in the United States to prices in other OECD nations, that we are about our prices are about 43% higher than the OECD average. It's not because of free markets. It's because government is doing so much to increase prices. Likewise, when consumers are not cost conscious, they don't care about price, but they also don't care about quantity as much. They demand more medical care. They're not as interested in economizing when it comes to quantity. This graph shows the out-of-pocket share spending versus real per capita health spending, which incorporates quantity as well as price. That also rose at a pretty steady clip, and that can also explain why, relative to other OECD nations, or relative to the OECD average, the United States spends or consumes about 49% more services than other nations, residents of other nations. It's because, relative to other nations, the United States U.S. residents pay for a smaller share of their health consumption, their medical consumption, out of pocket. You can see that down there, the out-of-pocket share of health spending for the United States is about 11%. There are only about 4 countries in the OECD where the out-of-pocket share is lower, and that 11% in the United States is lower than the out-of-pocket share in Denmark, the UK, and Canada. All in all, compulsory health spending makes up such a large share of health spending in the United States that it is 14 of the 16.6 percentage points of GDP that go to healthcare. What's interesting about that number, that 14% of GDP that goes to compulsory health spending, is that is a larger share of GDP. Whoops, wrong button. That is a larger share of GDP than every other nation spends on healthcare in total, voluntary and compulsory combined. So if you want to know the question is, why does the United States spend so much more than other countries do on healthcare? It's not because of free markets, it's because government is compelling U.S. residents to spend that much more. I see I still have some sand here. That's good. Okay. And there are other indicia that the United States residents of the United States have less freedom when it comes to their health care, and that the United States relies on free markets less than other countries do. This is a study by the U.S. government. It's from 2009, but I would imagine it still holds up today, that measures the barriers that government puts in the way of people accessing certain medicines, 86 different medicines. What it's measuring is, does the government require you to get a prescription from a healthcare provider, or what I like to call a government-appointed gatekeeper, before you can purchase certain medications? And what that study found was, in the United States, the barriers are as high, basically as high as they are in Italy and Netherlands, but the governments of Australia and the United Kingdom impose fewer barriers, or less burdensome barriers, to their residents who want to purchase those same medications. So by this measure, Australia and the United Kingdom have freer healthcare markets, or their residents have more freedom to make their own health decisions than residents of the United States. One that particularly sticks in my craw is prescription requirements for contraceptives. This map shows which nations require women to obtain permission from a government-appointed gatekeeper, usually a doctor, before they can purchase daily use oral contraceptives. The United States and Western Europe and Australia and some southern African countries, as well as Saudi Arabia, Japan, all require women to get a prescription, but there are lots of countries in the world where women have more freedom, and the government does not put that obstacle in their way. I still have time, and I think that the slides that I sent left a few slides out because I was concerned about time. So what I will say is this. That's the last slide that I've got. But the European myths about the U.S. health sector, the main one is that the United States health sector is a free market. I think I hope I've given you some reason to look skeptically on such claims. But there are lessons from the U.S. health sector that I think can apply to Europe. Principally, in between all of those, all of the regulations that we've talked about and all the ways the government intervenes in the U.S. health sector, there are sometimes these gaps where market forces do have a little bit of room to breathe. And we see wonderful innovations when that happens. For example, a series of experiments by an insurer in California took advantage of consumer price consciousness and got consumers to reduce the prices by making them price conscious for MRIs, CT scans, knee and shoulder arthroscopy, hip and knee replacements, lab tests, and other services, well below the prices that the insurance companies were able to negotiate. Why was this? Because when consumers got to see 100% of the savings instead of 11%, they were willing to change their behavior and switch to lower price providers, getting prices lower than insurers could get them. That is an important innovation. It shows how to make healthcare more universal, because if you want to make healthcare more universal, falling prices should be your obsession. That's how we bring healthcare within the reach of people who cannot afford it today, and it makes it easier for the rest of us to subsidize those who still cannot afford it. And unfortunately, while insurers had room to innovate in that way, the federal government still penalizes those sorts of innovations with implicit but very real tax penalties. Another innovation that has been able to take hold only in corners of the United States is integrated health systems like a private sector NHS or Veterans Health Administration, where the health plan and all the doctors and hospitals are part of the same corporate entity and fully integrated. This is a challenge that the rest of the U.S. health sector and the Danish health sector have not cracked yet. But this form of organization of healthcare delivery makes healthcare more convenient for the patient, because when my sister-in-law had a brain tumor removed, all of the clinicians she needed to see were in the same building. She didn't have to run all over the city to try to find this specialist or get to that pharmacy and then work things out between. They all worked it out. They talked to each other about the care that she was receiving, and she raves about the convenience of the care that she received. These systems have incentives to invest in electronic health records that make care more convenient and facilitate the communication between all of her clinicians and between the clinicians and the patient. And these health systems, the one that I'm thinking of is the only one that has broken through regulatory barriers in the United States, is Kaiser Permanente. They've used these electronic health records to improve care by doing research and identifying safer ways of practicing medicine and unsafe ways of practicing medicine, so that they can and others can avoid them. How many people here remember the drug Vioxx? One hand, two. It's got to be more than that. This is a COX-2 inhibitor, painkiller, took it off the market about 20 years ago. The reason the Food and Drug Administration took that drug off the market is not because the Food and Drug Administration found that it was unsafe. It was Kaiser Permanente of Northern California who pulled their electronic health records on millions of patients and said, this drug is killing people with adverse cardiac events. We need to take it off our formulary, and we need to tell the FDA about this. The market beat the government at something that supposedly only the government can do, which is identify unsafe drugs. And finally, the U.S. health sector the U.S. health insurance markets prior to 2014 had been remarkably innovative, not only developing health insurance products that allowed people, once they became sick, to keep paying healthy person premiums and keep that coverage, but that also filled in the gaps of the employment-based health insurance system that the government created, which tosses people out of their insurance just because they leave their relationship with their employer ends, which often happens after they get sick. The individual market for health insurance developed innovative products that even covered those people and fixed problems that the government had created. Unfortunately, and it could have gone even farther innovating in that direction, creating total satisfaction guarantees for health insurance. But in 2014, the government outlawed those plans and barred those innovations. So I think the lessons that the U.S. health sector holds for other nations as they try to make healthcare more universal is that markets naturally, through consumer price consciousness and price competition, make healthcare more universal by driving down prices. They naturally develop health systems and innovations and institutions that improve the quality of care, and they naturally develop health insurance products that make access to care more secure. So with that said, and still a little bit of sand in my timer, I'm going to say thank you all very much, and I look forward to the other presentations and any questions you may have.
Thank you very much, Michael, for a very interesting presentation. And we continue with Hans, I think. We fly over the Atlantic to Europe.
Yeah. I need somewhere to put this stuff here. We leave it like this, right? I'll take it over here. Don't keep watching this because it might fall at some point, but I want your attention to something else. So I'm not quite sure. Were these? Yeah, okay.
Thank you.
Yeah. You got some government support for that, I suppose, right?
Over the counter.
Okay, thank you very much. This is actually not my slides here, if I may say. Yes, can you help me? Yeah. But I can make his piece if you want. Yeah. No. Det var på skrivebordet.
Ja.
Yeah, and bring it up. Good. Fantastic. Thank you very much, and thanks for inviting me to this panel. I am not so often speaking in Denmark, although you could probably hear from the accent that I'm not only from Denmark, but from Jutland as well. So even speaking in Copenhagen is such a big honor, obviously. I worked mostly around in different European countries, but also in the US, so I know a few anecdotes about the US health system as well. I have a brother who lived in Arizona for the last 40 years or so, so he keeps talking about the issues there. I have been a client, if you like, of health systems around in Europe, unfortunately, but in Spain, in UK, in Belgium, and here in Denmark. So I have a lot of anecdotal evidence if you want to discuss with me later on. Now, I talked to Carsten about whether I should talk a little bit about what the EU is doing in this area. I'll do that very quickly, and then if any of you want to know more, you can always just come back, or you can keep the slides here. But I think the main thing to say is that EU has gradually got a bigger competence in the health area. And there's been a lot of political negotiations, but there's nothing like a good crisis. So COVID actually moved the whole thing quite a lot forward. And there's a quite substantial budget now in the EU for health issues. But I have to say, before you start yelling at the EU, as people usually do, they are not running the health systems. They are done by nation states and also from regions within the individual countries. So the few things they're doing is in the treaties here, so you can read that stuff yourself. But the thing about preventing and improving resilience to pandemics and so on obviously came from the COVID side. There's also the single market, so when you need your pharmaceuticals to get approved, they would have to happen to the European Medicines Agency, so that's a European thing, not a national thing, to ensure that there's free movement across the borders. The same goes for medical equipment of different kinds of things. You know, you'll have to do that in the European way. A lot of money there if you want projects to be financed from the EU. You can bid in and participate in some of these as well. There is a European health database on the way, which, by the way, will improve, I hope, the ways that health systems are talking together across the borders. They could help a guy like me who lives in different European countries. I've really had problems in getting my x-rays sent across the borders and so on and so forth. But that's something that we might be able to do in the future. But that also gives us a lot bigger market if we want to use it for research purposes, etc. You know, because we can actually then get data from nearly 500 million people. There's a new pharmaceutical strategy just come up here, which should try to balance the issue of pharma wanting good prices, as we just heard about, and consumers to have lower prices as well, but also the insurance companies and so on and so forth. And I just want to mention the Beating Cancer Plan, which is a big thing around in Europe, maybe not so much here, but the focus here is very much on prevention, early detection, and so on. We'll come a little bit back to that. But there's also set up, I think, some best practices for how to do screening on cancer based on European experience. There is one more thing that I wanted to tell you about, because this is actually my favorite publication, if you like. It's called Health at a Glance. And there's a long story behind why the EU is doing this. To tell you the truth, this is a place where you can get so much information about health systems in Europe on comparable data, and most of it done by the OECD. I don't have the latest version because you can't get it in print anymore. You can only download it, and the good news is it's for free. So you can just Google it and you'll find it. Every second year there's a new one out, so there'll be one by the end of this year. And in the meantime, in the other years, there are small country reports. Here's one about Denmark, there's about Sweden, there's about all the EU member states as well, and there's also the things that are combined in a companion report where you can basically see what is the update since last year when the great publication there come out. I can absolutely recommend it if you are interested in health. It's a really good source. The thing is that some member states were afraid that this was going to be used as a kind of name and shame. And you know how important health is in politics and so on and so forth, so you can basically say, hey, EU, keep your hands off. But the main idea behind it was not that. The main idea was to try to identify best practices and to ask the questions, why is it that somebody is doing better than others? And what is it, for example, we from the Danish side can export to other countries, you know, where we have favorable solutions. So the idea was to identify the best practices and emulate them, a kind of a PISA for health, if you like we have for education. So this was a little bit about the EU. If you want to know more, you can just ask, because I've worked with it for so many years. So I think I can answer most of your questions. I hope so. Otherwise, I have got to political training, so I can answer something different, which is normally so if the question is not very good. Now, I just want to say, and I don't know how that actually compares to what we just heard from Canon in this fantastic overview of the EU, of the American system, sorry. But if there's something that is common for European health systems, how different they might be, it is the universal access. So this discussion about should the whole population be covered or not is not really an issue, because we are based on universal healthcare with normally what I say, more or less universal access. Some countries are beginning to see problems, we come back to that, and therefore some people get easier access than others. And there are also people who can go beyond the public healthcare system and pay for their own solutions. But the European model is a universal healthcare system, and there's nowhere in European countries you can't find that. But we're different, and by the way, always backed up by government finances, because there are different kinds of models here. The first one is the difference in financing. There was a British Labour politician who lived in, the 1920s or so, called Mr. Beveridge. And he came up with the idea about the NHS, the National Health System, which is completely financed by either out of pocket, small amounts as we saw before, but then by tax financing. The main model in Europe was invented by a German politician who even lived a long time before, and who was the one who invented the pension schemes in Europe. At the time, the average life expectancy was 70.8 years, and pension would start when you're 70. So you can imagine, a little bit exaggerated, but it was not very costly to do at that time. But what he talked about was the compulsory insurance systems, which we also heard about from the US. But if you look to France, if you look to Belgium, if you look to Germany, some of the big countries around in Europe, they are still based on the insurance principles. And a lot of them are offered, of course, in connection with work. And if you're out of work, then you come into the social coverage via the government. So I hope that was pretty much clear. But there's also another difference between the systems, and that is the model of, how can I say, public hospitals only. So in the UK, in Scandinavian countries, traditionally, indeed in Denmark, we basically only have publicly owned and run hospitals. We have some smaller private hospitals, but they are outside of the system, and you will have to pay additionally by an extra insurance or your own pocket, to get in there. And I think few of them actually can do very advanced things. But I've lived in Spain, I live in Belgium. Around, if you go to Germany and so on and so forth, their public and private hospitals, they are sharing the market basically, and nobody really knows who owns what. And this is not creating more inequality because the private hospitals there in France and in Germany and so on are covered by the ordinary health insurance system or the health financing system. You see? So the inequality in the system is not really created by who owns the hospital, but rather who pays the bill. Okay? So we have, as I said, the different systems around. If we go to the primary health care, the traditional system in Europe has been the family doctor. Now we are getting privately run, but very much steered by the government reimbursement systems. And of course, additional services if you pay yourself. We are beginning to see much more modern types of primary health care. Next week I'm speaking for the Spanish Association for Primary Health Care. I have a nice meeting in Pamplona, which is good, but not easy to get to. But anyway, and these people in Spain have over the years developed a system which I think is common in Sweden now and other countries as well, which are the clinics that are very close to people. And multidisciplinary clinics where there's not only a doctor who can prescribe you the pills and so on. There are nurses, there are physiotherapists, there are dietists, there are people who can tell you how to work out your diabetes, and all those kind of things. And they're very close to people. They are all in districts close to the people. And they're doing quite a lot of the stuff and trying to have a more inclusive system where as many as possible are involved. We'll come back to that at the end. Secondary healthcare, we just talked about NHS or private public hospitals and so on and so forth. Tertiary care, we have public or private care homes around in Europe and so on and so forth. The thing is, of course, that there is not so much integration between the systems, which also the OECD has pointed out cost us quite a lot of money. That there's no coherence between the steps in the hospitals. One slide you just seen, but I have my version here, was how much do you get for your money? And I think it was more or less the same figures that we saw before. We had at least one explanation now why the US is spending so much without actually covering the whole population. I hope that's correctly said. Not in the universal system. But there are many reasons for that. I think also that the pharmaceutical companies have discovered that it's a good place to be to sell your stuff and so on. The big difference is also within Europe. But there's one thing, if we can go into a discussion about that at some point, I want to point at. And that is, putting more money in does not necessarily mean better quality. Now, I know you can measure quality in different ways, and I have at the end slide my take on how you could do it. But be careful. Also, when you hear the politicians say, we've just saved the Danish health system here because we found another 2 billion kroner. In a year, you might see an analysis and some clever health economists say, well, we didn't really get anything out of that, but there were some more increases in the wages of the doctors and so on. Anyway, so be careful with the spending, linking it to quality. Yeah. One thing is how we spend the money. 40% on the hospitals. differs, of course, from country to country, but that's where we spend a lot of money. Primary health care, about 13%. I think that's something we need to look at in the future. Long-term care, the last goodbye, 8%. And then, of course, we pay a lot for dentists ourselves, mostly pharma and medtech and so on and so forth. But surprisingly, to me, little on the primary healthcare part, which also is a question of the prevention and the early detection of diseases. I don't know how much sand I've got because that is removed, but I hope I have a few minutes left here. Carsten is looking at it. Because I would like to take a moment just to talk a bit about what I see as the main challenges for the health systems across Europe. We all know that the costs are growing, and if you are living in this country and have not read somewhere that Norway is making a lot of money, but the healthcare system is losing the money, then you might either be deaf or blind. And you should definitely see a doctor. But in any case, pharma is costing a lot more. We know that it's also more costly to have people on board. The public money has got other places to be spent. And one of the new things is defense. There was an American kind of politician who I can't really remember the name or trying to forget it, who said, you have at least to pay 2%, of your defense to be in NATO. And he might shout even louder in the autumn. But the thing is that I think we've discovered, because of what happened in Ukraine, that we need to spend more on the defense area. Of course, there's also still some post-pandemic issues here. But this is the real problem in Europe, and it's across Europe. I have a million of statistics about this, but I think it's enough to say that the number of people working and paying taxes will drop substantially. So less money into the system and fewer people actually to do the work. If you can't see on the back, I can see today we have about 65% in that group. And when the welfare states were developed and when I was a kid, that was much, much higher. So a lot of people to pay into the system, but around 2060, we can forecast that it's more or less around half of the whole population who actually works, and therefore can be nurses and doctors and so on, but also pays into the system. And the number of people over 80, and I find more and more comfort, with every day, that more and more people live longer, but 12.5% of the population over 80 in the next 30 years or so. And a lot of them are, if we're not changing our policies, are getting more and more sick. But that's quite a lot. What else is there? But the figures, and there's no need to go deeper into it. I do remember, though, that in 2005 or so, it's about 20 years ago, in the think tank in Brussels, we made a lot of studies about this, and we were forecasting exactly what was going to happen 20 years later. And at that time, I was still a little bit, a child of the 60s. Remember all our hippies from that time? I was not really. But anyway, said, make love, not war, which I still support. But at the end of my speeches at that time, I always said, make love and babies. And if we'd done that at the time, we would have had the nurses nowadays. But people were maybe listening, but they didn't do it. So about the solutions, we can come back to that. But there's a couple of other things here which I just wanted to talk about because it also gives an idea. Gives an idea about what you get for your money. This is the life expectancy in Europe in 2021, which was very much affected by COVID, by the way. Denmark moved actually quite up at that time, and I think Spain is still on the top, but they lowered a bit because they had a lot more mortality there. But you see, there are some differences here. The US actually, I think you didn't show that, Mr. Cannon, but it's also an example of maybe you don't really get out of the system what you should. You can comment on that. But you can always have the confidence that Poland and Romania are doing worse, if that's a comfort. But there's another thing, and I want you to have a little look at this, because this has been done by the last 20 years, more or less every year, and the pattern is the same. This is not just about life, or how long you live, but how well you live. And it's also measuring whether you can do what you want to do to be socially active or economically active without problems linked to disease, okay? And this is important also for the future. And when I show this in Denmark, people are basically, but that's because the Swedes can't count, or this is because. There is only one intelligent question to this, and that is, why? Because this is what you should try to find out. If it's a mistake in the statistics over 20 years, tell me. But if it's not, find out why males have so short, healthy lifestyles in Europe. And that matters because of demographics. We need people to be able to pay into the system and so on and so forth more than ever. One of the main reasons could be this interesting thing, I would say. First of all, the iris has beaten us. But in any case, Denmark is very high in cancer incidence, in the number of cancers amongst people. Again, a very, very intelligent question would be, why is that? In particular, because other countries close to us are much lower. It's about lifestyle, if it's about the way our health system works and so on. I just want to tell you from the health at a glance that this is something you can look at. And my two final slides before you beat me is what are the problems here and what can we learn from others? Generally speaking, yes, we have the systems. We all get treated everywhere. We have these issues here I talked about, fewer people to pay into the system, more of an aging population with more comorbidities, fewer people to work in this and other sectors as well. We continue to work in the silos as we always did. There's a very, very little of flexibility, I think. We're also working in national silos, which is one of the reasons why this publication is not very popular, because why can we learn from other countries? You can learn a lot. I'll come back to that. And then solving problems with another pot of money. This is what our government in Europe are trying to do. That's what Tony Blair started doing in the 1996 when he was elected. We put a little bit more money into the NHS. Did the life expectancy go up? Did the healthy life years go up? Not really. I think the big issue here is that the NHS systems in particular are running out of capacity, and that creates inequality. They were created to make certain that all these private operators would not create more inequality in systems. As I said before, if the public health system doesn't work, the winners are those that can buy themselves or via an insurance can step out of the public system and go before. Again, inequality is not a question about who owns the sector. It is about who pays the bill. Final things, the kind of solutions I would come up with, break down the silos, which is easy to say, and create more flexibility, and make certain that when you give an extra pot of money, it is based on now you need to do things in a different way. I also think we need to move from sick care to health care. I think it is very important that we detect diseases today at an early stage, because it's a lot better for the patient, I tell you from my own experience, and it is a hell of a lot better for society to discover the cancers at an early stage rather than the late stage. And we need to have people in there. And then we need to make certain that people are being screened, they have a diagnosis, and that we use AI and the technology to set up precise pathways to say, you have this disease, okay, here's the best possible treatment, and use the European Health Database for that as well. We need to eat and better. This one I would like, but I don't have the time, do I? Because I think we can learn a lot from the US. We are very good to discuss migration and immigration, and not integration. And I don't think that a country like Europe, like Denmark, that we will win a lot by trying to empty other countries in the world, developing countries, from their staff and so on. That's actually what Spain and Portugal and France, UK are doing now, because they have the language and the former colonies and so on. Okay, final thing, and I must just say that. Don't always talk about what it costs in healthcare. Look about the spending as an investment, and then try to see what kind of value that creates, not only for the patient, but also from society. This is what I used many, many years now, and you can just ask me, I'll send you papers and so on. How can you define value as a measurement for the return on investment in health? Not just a short-term cost views. Let's see what we get of value, and a dominant value for society is to get people into work, to pay into the system and not take out. And it becomes more and more important with the demographics that we have. Final thing, we can compare with other countries. Don't just say like I heard a minister say in Denmark, of course we can't compare with other lands. You can always compare with others. If you can learn something, do it. Thank you very much.
Thank you. Thank you, Hans, for a very interesting presentation. And finally, we get Kjell on the stage to talk about Denmark. Now we are going home to look at our own health sector.
This is better. Yeah. My first slide actually is actually to dispel some misunderstandings about Danish healthcare, and I'll be drawing on a small project I'm doing, writing, if you wish, the history of Danish healthcare. Whether I'll finish that, time will show. First of all, there's always been a visible hand in healthcare. When we look back, I gave historical examples. And what is also important, that is early decisions actually influence how we do things today. For instance, if we had followed Bismarck's ideas about health fund or Krankenkassen, we would have had a different healthcare system because we went a different path when we had our health fund law. So just some quick examples. In 1806, we had a royal decree to build hospitals in the counties, financed by the counties. And when we got the first, if you wish, real hospital, the Royal Frederick Hospital, which today is the National Hospital, that was also financed by the sovereign king. And actually, do you know where he got part of his money? And now we have to know your history. He got that from the profits of the postal services in Norway. So obviously that had to change when Norway became independent or associated with Sweden. The first document that actually regulates pharmacies and doctors came in 1672. It was such a document that we did not need pharmacy legislation for 200-300 years actually in that sense. And they established, for instance, uniform prices of all pharmacies in Denmark, and also location of pharmacies. Just think about what we have today. We also had how midwives should be educated, so there were early on intervention in a free profession. We also had the regulation about Quakers in that sense, and then we had the first Danish legislation about a voluntary health fund. It was voluntary initially, but with state subsidies, provided that they only were used for low-income wage earners. And actually note that here I said low-wage income earners, and actually there were provisions too to serve the poor. So early on, there were considerations of the with equity considerations. No more history, but actually the whole point hopefully go through. Now, if we look at the private-public mix, because actually Denmark is often used as a kind of prototype of socialized healthcare, etc., etc. So if we look at this diagram where I look at financing, where we have public finance and taxes at the top, private at the bottom, ownership, fully private ownership, and public ownership, then we can give a picture of any healthcare system. And public hospitals and home nursing, definitely, like Hans said, has always been public in that sense. Now, if we go to the other thing, general practice, office-based specialists, and non-profit hospitals is a different story too, so in that sense. And now if we go down here and look at adult dental care, where Danes pay about 85% of the bill, but it's privately run, etc., etc. And if we look at ambulance services, a lot of private provision, probably about 50% financed out of public funds. And then we have the pharmacies here, also privately owned. And if we look at commercial private hospitals, actually they got quite a bit of their money actually from public coffers in that sense. So what is important of this actually is, what is probably important is the financing, because actually we have a system of mixed ownership. So that's also important to understand when we look at the Danish healthcare system. And actually Hans already was into it, but I just wanted to put these systems of care, pure tax finance and by implication total public ownership, that's the beverage system. Then we have the Bismarck system, and then we have more market oriented. But what has happened over the past over the last 40, 50 years is actually that they approach each other and become more and more similar. So that's also a kind of a lesson from this. What is important when we look at Danish healthcare is actually the explicit patient rights. Even though it's government run, you have a free choice of GP, provided that you can find one. We have free choice of hospital, extended free choice of hospital, that is the waiting time guarantee is also important. And we have a similar thing for cancer, maximum waiting time for cancer, and those are very important. And actually, what is often overlooked, the extended free choice of hospital critically depends on private hospitals. I mean, if you cannot get your surgery at a public hospital, have waited 30 days, today actually 60, then actually you have a choice to pick something else. But if you don't have private hospitals, you are not able to meet these requirements. So actually that's an overlooked phenomena. Now tax financing is also important, because actually what we see, and if I had calculated, and I have actually, the correlation between the gross domestic income per capita divided by 10, but that's perfect in the same diagram, and then look at the spending on healthcare, there is a very close correlation, about 0.9 if you look at it. And what is important actually is that in systems like this, actually the health economy, that is funds available for healthcare, actually critically depends on how the overall economy is developing. It's overlooked, but for instance, it mentioned that we just yesterday or the day before, the government decided that we needed additional money for healthcare, more than usually given, but actually that was very closely tied to a high growth rate in gross domestic product. So that is also an important thing. And whenever we have a problem, have a crisis, most of you are so old here, you can remember the energy crisis. Look at how it happened to the gross domestic product. Move on, and now we're in the period with Poul Schlüter as Prime Minister, and he said he had to save the Danish economy, so actually cutting down public services, letting the private sector grow. And then we have here at the end the global economic setback. So it's actually there's a very close correlation that is often overlooked. And this we've already seen, so I would just go quick and use it, that just look at how much we use out of the gross domestic products. I have taken what countries that we usually compare ourselves with, and if you look at, apart from the United States, it's about a little bit of between 11 and 12% of GDP. And actually, hence, you'll be pleased to see that I even used the new version of that. And actually, for those who are interested, it's so nice that you can just click and then you get actually the underlying data. So it's easy to manipulate. And if we convert it to spendings per capita, we see a similar pattern. Now, let's look a little bit on reform thinking. Next week, on the 11th of June, the committee that has been looking at healthcare will come with its report. And what will be in that report will actually be that we will strengthen primary care very much. And actually the point of point of departure is something that Hans Martens also hinted at. In Denmark, we use 45% of health services are provided by hospitals, which is an unusually high percentage, and actually meaning probably that we're using hospitals in a wrong way. So what will come in the forum here is actually we will strengthen primary health care, and I think that is going to be an important agenda. It will require a lot of determination, because actually if you want to have unchanged healthcare expenditures, and you always do that in Denmark, obviously money has to come from somewhere. So growth in hospital expenditures will probably come to a slowdown, if not zero, and then the rest will go to primary health care. Just think about the doctors at hospitals, how they'll become and tell us how catastrophes will happen. And regional structure is also discussed, I'll get back to that. And also it's important in the mandate for the ongoing reform work, actually competition was not even mentioned once, although there is a recognition of the importance of private providers. And as it's the Sundhedskommissionen, and it will be published on June the 11th, and probably will start a lot of discussions. And also, it's important to say what I already said. If we look at the comparisons, Hans will already indicate that, but here we have percentage of healthcare, 47, Finland, we are far ahead. And to me, it indicates that for some reason we have put too much healthcare in hospital setting. And that's what is going to be changed. And I think actually, without reading anything, it's probably one of the figures you'll see in the report. So that's the important thing. And also it's pulled out of the OECD health data, not of the health at a glance, but if you go into it, you can see what it is. This is a very interesting and important slide. What is also, we should look at some of the successes that Carsten told us to, and actually we have had a markedly, and that's positive, centralization of acute admission hospitals. This is actually from a report by the National Board of Health, and this is what we have today. So actually, at the same time, we have increased the quality. We have centralized, say, cancer surgery, and actually cancer surgery is important to centralize because they give higher quality, etc., etc. So this is what we have, and that has taken a lot of work to get to this area. Then we have, should we stick to the 5 regions that we have now? They are politically managed, etc., etc. And actually there's a lot of discussion that all the ills of Danish healthcare is due to the regions. I happen to disagree violently because it's pure nonsense. It's not really about that, but actually it's a good issue to raise actually, do we have the correct structure? And that's also what will be recommended in the upcoming report, where government will be provided with a number of choices, so that's also important. Now, in a system like ours, we have to prioritize that, rationing as it's called. And I picked medicines because actually it's a good example of what is going on. We have established in 2017 the Danish Medicines Council, and essentially they should make sure that we introduced new drugs that were dispensed from the hospitals and do that in a uniform way, having what should be documented evidence for treatment effect, etc., etc., and also compare that to the price. So actually, if you like the term value for money, this is actually a value for money proposition. And once they have made a decision, then we have a drug wholesaler called Amgros that will go into negotiation with the companies. And the Danish Parliament unanimously, it's amazing, but unanimously set up 7 principles that should be followed for that priority setting. This is a screen dump from the homepage of Medicinrådet. So look here, they recommended 132 for general use, to be used in general in hospitals in Denmark, but actually rejected 82, and they had a partial recommendation in that sense. Some will say that we are denying patients access to this, but actually what we're denying is that people should not use something that is in a sense, of very low value in that sense. That is an important dimension. So it's actually based on value for money. And what is also important, once it has been published that it's not recommended, then a strange mechanism starts, because then the pharmaceutical companies come and say, oh, we have a special offer for you. We will give you a rebate, but you're not to publish it. So actually, there's quite a list going on. We have another priority setting thing where we're looking at how to reimburse medicine that is basically medicine that we get on prescription from our general practitioner. And in principle, this important committee is overlooked, actually, is that they make recommendations to what kind of reimbursement one can get. We have in Denmark 3 degrees of reimbursement. We have general reimbursement for prescription. So that means that the doctor can just write a prescription. Then we have conditional reimbursement, meaning that certain conditions, i.e. specific diagnosis, etc., has to be fulfilled. And then actually you have something here called single reimbursement, where you simply have to apply individually. Your doctor will do it for you in that thing. And actually, it's trivial from a pharmaceutical point of view. Reimbursement data leads to different levels of sales. Where do you think the biggest sale is? Highest for the unconditional, lower for conditional, and lowest with a single reimbursement. The pharmaceutical industry knows that. And now I'll give you 2 examples of what is happening of the very famous Danish Novo Nordic. This is Tresiba. This is example, I think, going back to 2016. And what they wanted at Novo at that time, it was decided initially that the prescription and reimbursement was conditional. And what they wanted to have that changed to general reimbursement. And to get that, they actually dropped the price by 28%. It's on public record in that sense. Something that is very much up at the time, where we have Ozempic. It has just been dropped 34. And actually look here, to avoid changes of reimbursement status from conditional reimbursement to single reimbursement. Because if it was moved to reimbursement, obviously the clever people at Novo knows that the turnover will drop. So actually they just dropped the price by 34%. And I remember still the then CEO, Lars Rebien of Novo, he said that actually they just gave a modest price decrease. That's what he's quoted for in the press. And looking at price setting in Denmark, actually we have a paradox, because actually we have free price setting. That is, pharmaceutical companies decide initially what price they want to introduce drugs to. That's unusual in a European context. But prices then have to be announced every 2 weeks to the Danish Medicines Agency, because we tie our reimbursement system to the cheapest drug of comparable drugs in that sense. And we have also generic substitution by GPs and pharmacies, and we've had that since in different forms since 1991. And the result has actually been that in Denmark we have the lowest generic prices of drugs, undoubtedly due to the substitution mechanism and intense parallel import. Thank you.
Yes, and now we move on to the debate. So I'd like all the 3 experts to get up here on stage with me.
Yeah.
Okay. Under those bright highlights
Yeah.
of the PowerPoint projector.
Yeah.
Kan du slukke for den der, Raoul? Yes, and I think we start. I have a couple of questions to your very interesting presentation, but I'll start with a quick round. If you have any comments to each other of what you heard. Michael, did you learn anything that you could take back to the United States to reform the health sector?
To reform the health sector, I'm not sure, but I learned, a little more about the Danish system and other European systems. But what I took away the most from these presentations is not that these systems, the Danish system or other European systems, are universal, but they're not. They're not universal. I think it was Hans who brought up the Bismarck versus Beveridge distinction. When you think about universal healthcare, I want you to think about two numbers. One of them is 1910, and the other one is 1883. Now, you may recognize 1883, but 1910 was the year that medical historians say that for the first time in history, a randomly selected patient with a randomly selected disease walking into a randomly selected physician's office had a better than 50% chance of benefiting from the encounter. Before 1910, medicine was as likely to hurt you as it was to help you. Now, about that other number, 1883, that was 27 years before 1910. That is when Bismarck founded the Bismarck model in Germany. So this was the first effort to at achieving universal health care, and they instituted it at a time when medicine was as likely to hurt you as it was to help you. That tells me this is not really about compassion. This is more about signaling that we care about people than actually helping them if you are exposing them more often to something that was going to hurt them. And you might say, well, this is not the case now. I mean, those are people from history. They're silly. They didn't know as much as we know right now. We're enlightened. Except we can see the same thing happening in Hans's slides. Hans said we have universal health care in Denmark and other European countries. And then we have silos and we have all these other things. There's an expression in an English idiom which is, what the large print giveth, the small print taketh away. And we can say that we have a universal system because there's a government guarantee of access to care for everyone. But if the government is managing that system in a way where there's silos and there's slippage between different providers and they're not working together, then it won't be universal because there will be harm to patients or help that they don't get because there's miscommunication between patient and provider, or miscommunication between provider and provider, or those silos are leading to medical errors or misdiagnoses. These things make the health sector less universal, and these are things that markets by themselves move to correct with the sort of innovations that I was talking about. So I think maybe the biggest myth that I could expose here today is that European health systems are not universal. No, first of all, no human endeavor is going to provide health care to absolutely everyone who could benefit from it. And what we see so we shouldn't expect any health system to be perfect. But what we see in these systems that are universal are we see governments imposing a single way of delivering medical care to people, and we see lots of stasis where problems persist year after year rather than a dynamic system that uses innovation to fill in the cracks and truly make healthcare more universal today than it was yesterday.
I tend to disagree because we have different definitions, because I think in Europe we have universal access. I'm not saying that everybody is being served in the same way. I'm not saying there's no inequality, etc., etc. But in principle, everybody in this room could go to the doctor in the same way as anybody else. So, and that's the same thing across Europe. So I do think we have, and we do not have a rule where people go to the hospital and they can't prove their insurance or whatever it might be, so they will only be stabilized. Why? When they're put in a hospital, they will be cured like anybody else, and they will find a solution. So I disagree. But I also wanted to say we can learn from each other because nothing is perfect, and I said that very clearly. And in this country and the rest of Europe, we can do better. So now I'm going to tell you where the best health system in Europe is. I cannot answer the question precisely, because it depends what you want to measure. Is it hospitals? Is it prevention? Is it whatever it is? But what I'm trying to say is that if you pick the best across Europe from all countries and emulate that, then you'll get the Europe's best health system. That, I think, is important. And then to kill. I will travel out of the country by the 11th, because you're just going to say, give the traditional primary healthcare sector more money. And I know the organization behind, I hope not, because I think we need to reform, and I don't know if I'll be shot on the way out, but I think we need to reform the primary healthcare sector in Denmark. I have to say, and I think my experiences from across Europe is that here, the first thing I see when I get into the office is a sign saying, remember that you can take maximum 10 minutes of the time. So that's a good lesson you get before you get in. And if you have more than one disease, you'll need to have another appointment. The second thing is it only takes 3 minutes, because that's the time it takes to make a prescription. And I'm a bit rude now, but may I just look at me? Am I fat?
No.
Last year, I had difficulties because I was actually 6 kilos more. My doctor said, this is difficult for you because I have diabetes 2 borderline, right? You need to get Ozempic. And I said, you are joking. No? You think you should do that? And she came with a very nice purse from it looks like, from one of the big fashion houses and so on, with a brochure inside. And I said, if you continue with this, I will change doctor, because you should talk to me about exercise. You should talk to me about lifestyle, how I can avoid doing that. But giving somebody like me with a BMI of 26 Ozempic, I think, shows there must be something going on that I don't want to hear about, okay? So this is my impression here. Whereas, for example, in Spain, people took me aside, talked to me about how I could do myself, gave me support for lifestyle and all that kind of thing. That's the difference. But we cannot just put it in there, because this is not just about this. This is also about the early diagnosis, and it's about being in a place where you don't have to run around town to get the necessary scannings or blood test or whatever it is. You have to begin to reform in the direction of mini clinics or something like that, in my opinion. Because, and let me say that also to you, when I have told you, because you might be so liberal to say, why is this guy so keen on the universal health system? Why is it that I want everybody to be cured early? Well, because of ethical reasons. But the main reason is we simply need people to be active and not sick. We need somebody to work hard and pay into the system and not take out again. Otherwise, we'll miss the universal system, which is the big nightmare of Europe. Thank you very much.
Kjell.
I just want two things. First of all, what is going to happen in primary healthcare is not as you think about, actually. So actually, there will be quite important changes if the government adopts the recommendations of the committee. Just for your information, I've been in the secretariat of that.
And that's why I just wanted to tease you to get you there.
So actually, that's one thing. But Michael, I think you are far off the point with, say, Bismarck, and said if they do not have modern healthcare. But do you know what the health funds did too? In Denmark and in Germany with Bismarck.
I might.
No, they provided income support if you fell ill.
Yeah.
That was actually important things. And that was actually making sure that the breadwinner had money for the family. Exactly. And that's the important thing. That's one thing. And I think they were far off the mark.
Far less likely to kill them.
No. And then actually all important, if you look at the introduction of X-rays, came into being in the late 1890s, 1890s, and that was introduced rapidly in most hospitals, at least in Denmark. So actually, your statement that people were most likely to die, say 1910, I simply do not believe it. Take also the contagious diseases. Take how tuberculosis was fought in Denmark and other countries. So actually, that's an important element too.
There's a vast number of procedures that occur today that can offer the patient no benefit, especially in the United States. In the United States, the estimated sort of preventable deaths due to preventable medical errors range from 50,000 per year to 400,000 per year. The truth is probably somewhere in the middle.
Too, yes.
Medicine is dangerous.
Yes.
It is in some ways becoming less dangerous than it was back then. In some ways becoming more dangerous, and it was quite dangerous back then.
But does that help to be price sensitive? Do we avoid these mishaps?
Yes.
By definition?
Yes. The evidence is clear on this. Randomized controlled trials, the Rand Health Insurance experiment, the Medicaid, the Oregon Medicaid experiment. There have been randomized trials in India. And every time someone conducts a randomized controlled trial that measures health outcomes among people who faced more cost sharing versus less, they find that the people with more cost sharing consumed less medical care than the people who got free or had to pay for less of the medical care out of pocket, but the health outcomes are the same.
Yes, yes. I was in the United States as a student when we had the RAND control trial, and we started it intensely, and it's still being intensely studied. And actually, it's right. Co-payment matters. That's the important thing. But still, all of them got some degree of government-subsidized healthcare. I hope you agree with that.
In the Rand Health Insurance
Yes.
experiment? Yeah, well, as part of the experiment. In order
Sure,
to,
but that's the whole idea.
control,
So that had to be very careful.
in order to control for income effects across groups, they provided the health insurance to them, and it was a study that used existing health systems and was designed to measure whether providing people quote unquote free universal health care where they pay nothing out of pocket would improve health. And they found that relative to giving people a health insurance plan with a high deductible, so lots of cost sharing, the people who got the free care got lots of additional medical care, but it did not make them healthier.
It takes too far to go into details. I know the
details get even more exciting.
I know the RAND people, so that's okay.
Hans?
Can I just ask you a small? I'm trying to get more news out of you. You know what we can expect. No, but the thing is that I've been thinking. You know, I'm a fan of diagnosis, right? But not only diagnosis, but then after that, also to set up precise pathways and so on.
Yeah.
So we need to make that available for people not going long way to a super hospital to do that. But have you been considering, or what is your opinion about public-private cooperation? And I'm saying that because during COVID, public-private, which we normally don't really talk about here, worked well for the testing, but also for the vaccinations and so on. Why can't we have just around the corner here a diagnosis center, you know, open for all, universal access, and I can go in there and have a blood test, you know, and I can get a result, and maybe they can help to set up the pathway. Will we not do that in Denmark?
Part of the mandate, so I'm just sticking to what is publicly available, part of the mandate of the Health Commission was actually to look at pathways, how to integrate care, etc., etc.
Yeah.
So there is considerable attention to that.
But public-private?
Also public-private, because actually there's a separate chapter on private health care and also the health insurance issue.
And as you were saying, if we don't have the private hospitals, the only alternative
Exactly.
is to go to another country,
Yeah,
which you can do.
and pay for it.
No.
With the EU, you still have to pay considerable.
But that's not what I meant. We have a guarantee for treatment, right? And if it, as we sometimes see, is not being honored, right? Then you can go either to a private hospital, and they would normally in Denmark not be able to do the complicated operation. Then you can choose to go to UK or to Germany or something
For
like
free.
else, paid by the government. Yeah.
Yes.
So you see, we're not only universal in Denmark, we can use other people's systems as well.
Yes.
Whatever works.
I have a few questions, and then we move on to questions from the floor.
Yeah.
I have my roots in microeconomics, and because of that, I'm very fond of Arrow's article from 1963 about actually the start of health economics. And I think that we can all agree that it's a fundamental demand problem that the consumer doesn't decide his demand of healthcare. It's the doctor, the physician who does that. And we can probably also agree that in all healthcare systems we have some over-treatment problems. The OECD estimated that around 20 to 30% of all treatments are at best nothing worth to the client. And I said this fundamental problem with asymmetric information, where the doctor, of course, in some way, direct or indirect, get the payment of the number combined with the number of treatment. Which one is the best system to solve that problem? Is the market system, where the consumer get more market power to decide for himself, or a system, as Kjell presented, with more prioritizing committees trying to choose the right treatments and the right kind of medicine? Do you have any comment on that?
I think it's important if we look at Arrow's 1963 article. And Arrow is the economist. He got the Nobel Prize, and he's actually also who developed the theory behind perfect markets. But actually his observation when he wrote his path-breaking article was actually that in some cases the market does not work the way we think about it. And that was actually his important observation. He did not then see what kind of healthcare should be provided, but he called attention to the fact that if you blind and if you simply think you can transfer traditional microeconomic theory to healthcare, you're way off. That's basically his message.
But I
disagree. And Arrow's article was very important. It's one that health economists like to cite more than they like to read it. What he did was he identified a number of potential market failures in healthcare. What is a market failure in health? What is a market failure generally? A market failure is a circumstance where there's a potential exchange that could benefit both sides, but because of some problem or other, that exchange does not happen. So what that means is that wherever you see a market failure, there are incentives for someone to come in and solve that market failure. And I could talk about ways that markets have done that in healthcare. Kaiser Permanente is one of them. Integrated health systems is one of them. But what Arrow did was he said, healthcare is so complex. Health and medicine, the human body are so complex that there are all these sorts of ways that markets don't adhere to a simple supply and demand curve model, and some transactions might not occur that would benefit both sides. He did not say that therefore government should step in and do everything, which is what everybody who wants government to step in and do everything thinks when they read Arrow, and they invoke Arrow as though that was just some ritual incantation that they have to say that will bless anything that they want to do in healthcare and give his pedigree to their pet ideas. That's not the case at all. In fact, people who have read Arrow's 1963 article know that Arrow said things like health insurance coverage increases prices, and therefore that there's a tension between broader health insurance coverage and making healthcare more universal. They know that Arrow also said that for people who already have an expensive medical condition, health insurance in this strict sense is pointless. Pointless. Do people who invoke Arrow as a justification for universal health care systems, government-run healthcare systems, cite that part of his article? No, they don't. What they do is they try to provide a subsidy that they want to provide to those people through a massive system where the government provides health insurance to people the market would provide health insurance to anyway, instead of just providing discrete subsidies to those people. It is possible to provide subsidies to those people for whom Arrow says health insurance is, in a strict sense, pointless, without interfering with the market's ability to make healthcare more universal for everyone else and for them at the same time. But that's not the lesson that most people who want a universal health system draw from Arrow. They just say, well, you know, market failure, there's no such thing as government failure, so let's just have the government take over the whole thing. And it'll be more compassionate when, in fact, it ends up being less so.
May I just say that being the one who invented health economist, I'm not sure I support that very much, because I think there's been more damage than good. But in any case...
Damage than good from what?
From health economists. Because,
because
the focus has always been about cost and not most other things. Just the thing about the OECD report, it talked about 25 to 30% of waste in healthcare, so spending which doesn't benefit the patient. But that was not just maltreatment. It was a bad diagnosis, it was bad pathways, but it was also lack of coherence and waste of public and private money and all that kind of stuff. But the only thing I want to warn against is to basically see over-treatment means you don't have to go and get the early diagnosis. For me, it's better to be afraid of the disease than of the diagnosis. And therefore, because it's better for the patient, it's better for the society to have it done in an early time. And don't always just measure by the cost. That was my point. Think about what I said about the value kind of thing. Take it a little bit on the long term and say, what is it for priorities we need? And you know exactly what we need in Europe. We need people who are socially and economically active, and they should keep on doing that.
But
Even in high ages.
there could even be too much preventive care, though. There was this study of, what was it, Netherlands, Sweden, Poland, of encouraging colorectal cancer screening, where 84,000 subjects divided up into a control arm and an intervention arm, where the intervention arm got encouragement to get a free colonoscopy. And who doesn't want a free colonoscopy? They got encouragement to get a free colonoscopy.
A lot of people don't.
And 42% of them, but 42% of them did. So 42% of the people who got that encouragement did, but there was no difference in all-cause mortality between the people who got the encouragement and the colonoscopy and the people who did not, or who did not get that encouragement or those additional colonoscopies.
You know that
which suggests that, I mean, there hasn't yet been a study showing, that I'm aware of, showing that colonoscopy, colorectal cancer screening with colonoscopy results in lower all-cause mortality. Yes, lower colorectal cancer mortality, but not lower all-cause, and that's what we care about. And so this suggests that a lot of preventive care, a lot of cancer screening even, could be what we call flat-of-the-curve medicine that is waste because it's not producing any actual benefit.
No comments, but I forgot one thing. The use of AI in the future and the data system. I hope that this can be a breakthrough in from diagnosis to the right treatment, or to the best optimal treatment.
You must.
Yeah, but I agree with you, Michael, that it's important that people read Arrow's article, and a lot of people don't. And also I see that people interpret it differently. I think you and I interpret it entirely differently, even the mathematics on the health insurance. So actually it is important that we have the same frame of reference and then can discuss it based on that frame of reference. I was incidentally involved in the early stages of a randomized trial of colorectal cancer in that things. And actually I think, if I remember the result, we proved both on a Danish sample. So actually we have as a
all-cause
screening.
mortality?
Yeah.
Okay, I'd be very interested to see.
But it's for my recollection.
Okay.
Yes. What is so fascinating about healthcare is that you can discuss market failures for a very long time.
Yes.
But and as I said, I had my professional roots in microeconomics, but then I fell in love with public choice, who is actually about politics failure, government failure, and there's also a lot of them in healthcare. And I was thinking about Hans talking about the problem of not investing enough in preventing illnesses instead of curing them when people got really sick. And you have some figures, showing that most of what happens in the Danish healthcare system happens in hospitals, because we have prioritized hospitals. So maybe there's a government failure here that we are looking at, because people who are sick here and now is also a bigger political problem than people who are sick tomorrow. Is there a system using insurance or anything that will solve this better than a government-based system?
I teach my students to be careful to make a distinction between market failure and government failure. I did a lot of work in public choice actually when I was young in that things, and that called attention to government failure, meaning that both systems are imperfect. So actually we just have to be careful how we apply the argument about government failure and about market failure, because both failures do exist and are harmful to people.
I included the public choice slide in my presentation just for you, Carsten. It was the one about the lobbying expenditures. And the fundamental dynamic that takes hold whenever the government intervenes in really any sector of the economy, but we'll talk about healthcare, is a given regulation, a given tax provision, a given government subsidy is going to become a source of revenue for someone. Maybe it blocks competition for my medical device company, or favors healthcare expenditures over other expenditures, or that subsidy comes directly to me but not to my competitors. Or maybe just the general presence of subsidies leads to a lot of low quality, high cost medical care. And all government subsidies that are not cash do that. They result in low quality medical care. In every health system, what we want to do to make healthcare more universal is we want to replace high cost and low quality care with low cost and high quality care. But if the political system is what is going to be making the resource allocation decisions about moving, if the political system is going to be the one that has to move resources away from high cost care to lower cost care, or away from low quality care to high quality care, the problem is that every dollar that they want to move from this category to that one, every dollar of high cost, low quality medical care or health spending is a dollar of income to somebody. And that somebody has a lobbyist. Now in the United States, that might be the hospitals or the insurance companies or the pharmaceutical industry or the physicians. Here, I understand you have a very robust nurses lobby. This is another one of these groups that do not want change if it is going to interrupt their revenue streams. In a market system, they don't get a veto over lower cost, higher quality care. In a market system, someone gets to offer the consumer something better, and if the consumer likes it, they survive, and the resources don't go to the high cost people anymore. We get more universal health care and higher quality health care, but that's not how it works in a universal government run system. Where the government is providing the funding or mandating that you spend your own funds on healthcare, it develops certain rules and creates certain revenue flows. And the moment anyone tries to interrupt those revenue flows by saving the taxpayers or the consumers money, you get what we had in that chart of mine. And it happens, you know, I defend our current president in his efforts, Democratic president, in his efforts to reduce the prices that the Medicare program is paying for prescription drugs. I wish he would go farther than he's trying to go right now, but he's having a very hard time doing it. And why is that? Because the pharmaceutical industry spends almost 3 times what the defense industry spends to lobby Congress. And they're also spending money to lobby the Medicare agency itself. And mobilize seniors who worry that they might not get the drugs that they want anymore. And they're very effective at stopping the US government from doing anything efficient in healthcare. And I think the same thing takes hold, the same dynamic takes hold, albeit on a smaller scale, in every universal health system you'll find in Europe or abroad.
Hans, comment before we
Yeah,
move on to
no, because I
questions
think
from
we
the floor.
talk too much. I think we should have some questions.
Yes,
from,
questions from the floor. Please say your name, and if you represent an organization, please tell us that too. Mia?
My name is Mia Grandal, and I'm a medical doctor and head of a thing.
Ansett?
Okay, I'll start again. My name is Mia Grandal.
Mia helt op til munden.
I'm a medical doctor, and thank you for 3 very interesting talks. I think you're all missing a very, very important point that health is not created in the healthcare system. It's created outside in society.
I mentioned that.
And we have a big problem in Denmark that the government won't raise your prices on alcohol and cigarettes. And if you want to stay healthy, you don't need to eat medication. You need to move, exercise, don't drink, don't smoke. When people come to the healthcare system, they're sick, and we can help them, but we don't make them healthy. Do you have any comments on that?
Yeah, because I had a slide that basically said we need lifestyle changes as well if we want to go the right way and preserve our system. You saw that, right? And I didn't have the time because of this bully there, you know, to go into it, right? But that's what I meant. And I mean, when I talked the story about Ozempic versus, 10,000 steps a day, this is what it's all about. And if you want to have the answer, for example, on the healthy life years that I showed to move up there, I think you are absolutely on the right spot. But how the hell do we do that? But I didn't say that. How do we do that? And I think it's a complete transformation that you just don't do like that, because it starts in school and and so on. But it's about habits. But I think it would be good if we could do it at a broader European scale as well, because people do travel and so on and so forth, right? But I'll stop there.
It's well documented that if you raise the prices on cigarettes, young people won't start smoking, and they don't drive to the borders because they don't have driver's license in Denmark when they start drinking and smoking. So the politicians keep arguing about border trade, the market at the borders.
But
But I think that's answer to raise the prices.
It is one answer, but it's also about changing the behavior. You need to learn that.
I was just curious, Michael, what's your take on raising the taxes on tobacco and alcohol?
First, a lot of the things other than medicine affect health. The problem in the United States is we spend so much money on health, we don't have anything left for. We spend so much on medicine, we don't have as much left over for other things that improve health: education, nutrition, housing, and I think that could explain part of our poorer health outcomes in the United States. When it comes to whether and to what extent people should value health, I mean, I don't drink. I've never smoked. Okay, there were a couple of cigars, but I didn't. But I don't want to ever have another one again. And I think life is much better that way. And I think, but at the same time, I don't want to shame people because they are obese. I don't want to shame people because they drink. I don't want to shame people because they smoke. If I want them to be happier, I think they can be happier if they're not engaged in certain behaviors. The way for me to do that is to try to persuade them. I think because I think that a belief in human equality and the equal dignity of all people necessarily requires that you respect other people's values, even if they are different from their own, your own, even if they don't value health as much as you value it. Because if you don't, you're showing a fundamental lack of respect for them. So I think even more than promote health, I think we need to promote respect for other people and their choices. And try to persuade them, by all means, try to do that. Earlier today, I was sort of saying, go Bernie Sanders, try to shame Novo Nordisk into lowering its prices. I don't have a problem with that sort of persuasion.
Very brief. This is water, just to let you know. But the other thing is, I think if you are living in a universal health system and we have collective financing and you want to be part of that family, other people's health is also my concern.
Which is another reason why you should not have a universal health system, taxpayer finance, because it makes you think that my health is your business.
Yes.
And if you want to subsidize my poor choices, then subsidize them. If you don't want to subsidize my poor choices, then don't. But don't make it sound like I am imposing a cost on you. You are voluntarily voting for the politicians who are creating and perpetuating this system that imposes those costs on you. It is the height of irresponsibility to try to change someone else's behavior so that you, when you are making an intervening decision, that could protect you from those costs.
Another question. Take it
Do I have
in the break.
My name is Olav Nielsen, a private contributor to CEPOS. Thank you for 3 very interesting presentations. I think that life expectancy is extremely interesting. This country, with a Gini of 0.30 compared to the US with a Gini of 0.40, there is a difference between the upper 20% and the lower 20% of 8 years. That's astonishing. Or maybe even more. Has any country solved this problem? How is it in the long-living countries like Spain, Japan, Hong Kong, Iceland, Sweden? And is there anywhere you can find data? Because I think this is extremely interesting. Is there anywhere you can see data of life expectancy for different fractals in the different countries? I would very much like to see that.
It's available.
Thank you.
Yeah.
Inequality is different across Europe, but one of the ways is the way that your primary healthcare system, catches in people of different levels and so on. But I think I will keep it short, and then we can have a little chat afterwards.
No universal health system solves it.
And my second point there was that I think you mentioned countries that does it well, for example, Spain and France, because they reach out, right? What?
They do it on average lifetime. I don't know how it is with a difference. If their long living lives very long compared to the long living Danes, or the long living Danes live as long as they do.
But don't forget that life expectancy is one thing, healthy life years is another.
Yeah, exactly.
Any other questions from the floor? Yes.
My name is Finn Ziegler, and I'm a consultant privately running alone, so I don't represent any organization apart from that. I want to ask a question here again about the subsidies, right? So I think all three of you made a big mistake. You were talking about healthcare. What you are really talking about is a sick care system, right? And what we do in Europe and the United States is subsidizing sickness. We are subsidizing it in two ways. We are subsidizing it by providing care for the sick, and we are giving income support, right? And that causes a moral hazard, because people, they will then live less healthy than they otherwise would do, as the lady explained before, right? So if you want to stick with a system of universal healthcare, do you have any concrete suggestions for how we can change that?
I just have one sentence. I said it on the slide. Go from sick care to health care.
Yeah, but how?
Okay.
That's a
Do
good
we have another 2 hours?
Kel, do you have
No, I
any?
just say, Finn, you're right. And I've seen nowhere where they've succeeded
No.
in that thing. Everybody talks about it, and nobody wants to enter it. And maybe actually, Michael has a point. There is so heavily vested interests in providing sick care. I think that is an important consideration. When we talked about unnecessary care, you have to remember that those nurses, those doctors who will be hit if we cut it away, actually they are violently opposed to it.
But they will have enough
So,
clients with the
what I'm
demographics.
saying is, ideally yes, but there are so heavily vested interest that you don't. I would never say it's virtually impossible, but that will be a very long haul.
I think the questioner made a mistake when he suggested I made a mistake. I was talking about health care, not just sick care. I agree that a lot of what we do in the United States, certainly, and in countries around the world, is just taking care of people after they're sick and not keeping them healthy. I talked about some market innovations that do keep people healthy, and there are others that I didn't talk about that I could, but the ones that I talked about were health plans like Kaiser Permanente, that because they're an integrated prepaid health plan and health system, they internalize the long-term costs of preventable medical care. So they have incentives to invest in prevention like other insurers don't. The state and federal governments in the United States have used regulation to block those plans. They have penalized them through the tax code, and they've subsidized the competition, sick care. In addition, one of those things, the penalties that the tax code imposes on those plans, penalize plans that stay with you for life. You only avoid the penalties if you enroll in employer-sponsored insurance, which does not stay with you for life. So you do not have a relationship with an insurance company that lasts a lifetime. So those insurance companies don't have an incentive to invest in prevention because the benefits will accrue to some other insurance company. U.S. workers change jobs about 12 times by the age of 52. What insurance company is going to make those investments when it's going to accrue to some other insurance company or some other employer? And if we want to prevent smoking, if we want to prevent obesity, if we want to prevent unhealthy behaviors, then what we want market prices for health insurance. We want insurance companies to be able to discriminate on the basis of health and health behaviors, because fewer people will smoke if their health insurance premiums go up because they do it, much like a tax on cigarettes. Fewer people, when they can see the financial cost of unhealthy behaviors reflected in their health insurance premiums, fewer people will engage in those behaviors, and some of them still will engage in those behaviors, but you know what? They'll be paying their own way, and so nobody has any business telling them that they need to stop. And we get less societal discord for that reason. And I could also talk about how market competition among cigarette companies in the United States was making cigarettes safer until the giant incumbent cigarette company got the government to use regulation to stop that competition and kept cigarettes unsafe.
Hans?
If you want a longer discussion from my point of view, you're welcome to contact me. I also want to say that this is not just about money. We talk about money all the time. There's also an ethical dimension into this. Can I also just tell you that in 2015, 16 or so, well, I remember better the 90s, but because of the Danish practitioner, doctors actually got per patient an extra sum of money to talk prevention to them. Have they actually used that, you think? No. So they were paid to do that.
Kel, any comment?
might
Just
lose money
to
if they
return
Yes.
to Finsila's question, actually, I don't know, actually, all decision makers and all opinion makers in Danish healthcare have visited Kaiser Permanente. And the interesting thing is they come back and see it's very difficult to translate into reality because there was a considerable interest, and we also had visits of them and everything. So actually, just copy paste is extremely difficult.
Well, as I understand it, there's been no effort to try to copy paste it, because what you would need in order for those sorts of health plans to emerge and thrive is you would need low barriers to entry into the market for clinicians, low barriers to entry into the market for health insurance, and you would need price-sensitive consumers so Kaiser Permanente can take advantage of the fact that they practice more efficient care and can keep the health insurance premiums lower. They tried to enter North Carolina. This has happened in a number of states where they began in Northern California and have spread to some other states with limited success. When they tried to enter North Carolina, Alan Enthoven and some others reviewed the wreckage after they failed and said the reason was that the consumers were not price sensitive. The reason that the consumers were not price sensitive is because the government, the federal government, has this tax preference for employer-sponsored health insurance that made them price insensitive when purchasing health insurance. So so unless Denmark has done at least half of those things, they haven't really tried to make a serious effort to create those sorts of health systems. Now you could try to create one from the bottom up or nationalize the whole thing in the way that the British did, and you would get, well, basically the NHS, but I think the Kaiser system probably performs better.
I think it's easier to cooperate, to find, to emulate ideas in Europe. And you mentioned Sweden, or you did, but they are actually performing a hell of a lot better in many, many areas these days. So why are we not looking up the way they do preventative care?
Maybe one last question from the floor. Yes? Just a moment.
My name is Soya, and I'm a board-certified cardiologist. I've been working at the public hospitals for 26 years and a senior director in disease prevention in Novo Nordisk for 2 years. Now I'm back in public hospital and never been happy. I'm working in Region Sjælland, where when I went back, I was very terrified because I've never seen so many people without teeth. And I think you're forgetting that one very interesting thing you said was that you wanted to refer more patients to the general practitioner. The most common patients, my colleague, who's a board-certified diabetologist, and me, we're working together. They are very, very obese. They have 4 to 5 to 6 other comorbidities. Yeah. So every time we try to refer them to the general practitioner, we get them referred to us. So I'm very excited to see what the Structure Commission
me too.
will provide, because there's only 1 to 2 physicians in that group, and I think that we have to get more general practitioners, but you also have to make them be better to handle the comorbid, the multimorbid patients, and I think you have to use the specialists at the hospital to go to the general practitioners. You have to take I know that specialists at hospital, it has been increased with 40%, so you have to take the specialists from the hospitals to go to klyngerne, to go to the general practitioners and to help them. Maybe with teleconferences or easy accessible specialists.
This is what they do.
That's what you have to do.
Yeah, but that's a good idea. But if you want to relieve the hospitals by putting people into the primary health care, that's wrong. You need the primary health care to early detection and setting out the diagnosis and all that kind of stuff. Not the other way around, because that's just a money machine. In and out, and then you have to deter from the care centers, from the communes, back to use the primary health care for what it should, and then change it, as I said, to be able to do these kind of things into groups, into smaller clinics, at close to the neighborhoods, rather than the family doctor.
I think we should make drive-out specialists.
The what?
Yeah, drive out, going out from the hospital, visiting, yeah. And actually, I
We
think
had that in the old days, right?
yes. And if you look at Køge University Hospital, I think actually they have, I don't know how many telephone lines that are open, so general practitioners can call in and get assistance from the experts in there. That also calls for a different role for hospitals, not only the most specialized treatment, but actually providing support for the primary health care, and that's extremely important. We see that in a few places. Køge and Kolding Sygehus are two examples of that happening. So actually, I think that's also the way forward.
Michael, any comments on that?
I'm guessing that those multimorbid obese patients are unprofitable for the general practitioners, and that's why they're referring them back to you.
No, it's because of they are multimorbid. They have obstructed sleep. They have diabetes. They have ischemic heart
So you're
disease.
referring them
they
for
have
preventive?
So I get them. I am a rehabilitation physician, cardiologist. So I see them when they have been through a coronary angiography or coronary bypass, and then they have all these comorbidities, which is too much to handle for the general practitioners. So every time I have to say, now they're good. Now we are discussing, can we refer them back to the general practitioner before they have reached treatment goals? Because we have to save money. And we have said, well, do LDL have to be below 1.4 millimole per liters before you refer the patients? Yes, I say it has to be, because when I refer them back to the general practitioner, quote, nothing happens, sorry. And then they get another stroke, another ischemic heart disease, and we see them again. Then we have to start all the way around.
Okay.
So I don't know if they're not profitable. It's just because they're very complex. They have these 4 to 5 to 6 diseases, and it's very complex to have such a patient. In Region Sjælland Holbæk, we tried to make a clinic for multimorbid patients. And this is really the way to go. If the general practitioners is not the way to go, and now I'm not talking about prevention, because of course I agree to all that. Now I talk about these already sick patients that we have to handle.
So I can understand the problem conceptually. These patients are not following your post-op instructions. When they go to the GP is not helping them follow the post-op instructions. It could help prevent further complications. Is that the case?
Yeah, or maybe they say, now your LDL is fine, stop the statins, or you know, it's very complex. Maybe they cannot afford the medication.
Markets, as a matter of course, create health systems that internalize to the system the cost of the additional care that those patients will need if they don't adhere to post-op protocols or preventive care or whatever. So create incentives for those health plans, not only to be more aggressive in trying to get those patients to follow those protocols, but also finding the clinicians with the least amount of training, the lowest cost clinicians who can help them with that adherence consistent with quality and keeping them from ending up in the emergency room again. It seems to me that the situation that you're in would occur less frequently if the people who are designing the workflows and paying for all this medical care actually had a personal stake in whether these patients were going to waste the health system money. In a universal government-run system, no one's money is on the line because everyone's money is on the line. But in a private system with competition, there will be people whose own money will be on the line in that case, who will not only lose money but gain a reputation for low quality care if they tolerate the sorts of things that you're describing. But those sorts of things can persist in a system where there's less responsibility for these sorts of outcomes.
Yeah, I thank you, Michael. I think we are out of time. We can continue the debate afterwards, maybe. But I think now we will give a big hand for our 3 experts.
That's great fun, Hans.
Thank you for a very interesting debate and very interesting presentations. And thank you all for coming today.